Hello and good evening and welcome to our live TIF Talk event. I'm very excited to have our special guests. We actually have 3 guests tonight. My name is Andrea Millers and I'm with Endogastric Solutions. And today we've got 2 physicians. We've got Dr. James Conti. Hi, Dr. Conti. Thank you for being here tonight.
Thank you.
And we also have Dr. Choe, Steve Choe. And thank you, Dr. Choe, for being here as well. And you're welcome. Lastly, we've got Annie, and she's actually one of Dr. Conti's patients. So just to give you a little bit of background, but before we start and give you the background of these physicians, I do want to remind everyone this is a live event, and at any time, if you guys have any questions for either Dr. Conti or Dr. Choe, and even Annie, please feel free to type your questions in, and we'll do our best to answer them tonight. So a little background on Dr. Conti. He's a board-certified gastroenterologist with Eisenhower Medical Associates in Rancho Mirage, California. His areas of specialty include GERD treatment and diagnosis, therapeutic endoscopy, gastrointestinal cancer, and inflammatory bowel disease. Dr. Conti earned his medical degree at Ross University of Medicine in Miramar, Florida, and his internal medicine and gastroenterology residencies and GI fellowships at Albany Medical College and Medical Center in Albany, New York. Dr. Choe is an Advanced Foregut Surgeon with Eisenhower Medical Associates and also Rancho Mirage, California. Dr. Choe earned his medical degree from Drexel University College of Medicine in Philadelphia, Pennsylvania. His general surgery residency at Hahnemann, am I saying that right? Hahnemann University Hospital in Philly, and continued with subspecialty training in minimally invasive surgery at the Allegheny Health Network, Esophageal and Lung Institute in Pittsburgh. Dr. Choe specializes in laparoscopic and robotic treatment of esophageal and gastric diseases, hiatal hernias, esophageal motility disorders, and GERD. So that was long-winded, but we really wanted to make sure we gave you guys both your accolades and what you do. Before we start, do you guys want to talk a little bit more about your practice specifically? We all know that you're in Rancho Mirage, but I know you have probably separate practices, but just let the audience know a little bit more about you guys.
Sure. I'll start it off, Steve. So I've been practicing in Rancho Mirage now for going on 10 years in Southern California. We love the area. Both me and my wife are physicians here. And we enjoy everything that Palm Springs and the desert area have to offer. I've been with Eisenhower Medical Associates now for 8 years. And me and Dr. Choe started this collaboration going on about over a year now. It's been a little bit of a rough, bumpy year, starting a program out during the COVID-19 pandemic. But we're excited to bring new technology to the desert. And hopefully people will enjoy this talk and get some more information out about GERD treatments and different options for anti-reflux surgery and some of the newest cutting-edge technologies that we're really trying to pioneer here in the desert.
Fantastic. Thank you. And Dr. Choe?
Yes, I've been in the desert for 5 years now, 4 years at Eisenhower Medical Center, treating patients, the full gamut of general surgery, specializing in foregut for GERD patients, hiatal hernia, esophageal cancer, gastric cancer, along with this, your run-of-the-mill appies and gallbladders and everything. I'm excited to start this with Dr. Conti because it's a need that really is prevalent in our local community and abroad, and to have this technology that we can give the most advanced care to our patients is really tremendous and exciting for me. So
fantastic, thank you. And Annie, where are you coming in from today?
I live in La Quinta, California. I've been in the Coachella Valley for about several years now. Originally from Austin, Texas, and I came to California with GERD.
Okay, well, she's actually from Austin, and I was from California, and we switched places. I'm now in Austin, Texas. So Quite the difference over here. But thanks, guys, for being here. Let's go ahead and start talking about GERD. Maybe Dr. Conti, you can give us an explanation of what is GERD and what could patients potentially be feeling or suffering from. What types of symptoms would one expect if they were suffering from GERD?
Sure. Well, acid reflux disorders in general, which GERD covers quite a few different ones. Typically, I think the most familiar that patients are is with standard heartburn, but there are quite a few different presentations that we see for acid reflux disorders, including epigastric pain, difficulty with pain after meals, then all the way up to, in addition to heartburn symptoms, we sometimes deal with airway disorders, patients having chronic cough, sometimes difficulty swallowing, fullness in the throat. So there's a variety of different presentations, the most common probably being heartburn, but it also can kind of present in many different other symptoms as well.
Awesome, thank you. And before we ask Annie a little bit more, what do you generally or start telling patients to do when managing kind of that initial managing their GERD symptoms?
Sure. I would say there's probably been a significant evolution in GERD treatment over the last decade. As a gastroenterologist, we've kind of seen this transition of patients, especially since the wide availability of acid reflux medications now are really commonplace in most pharmacies. And so a lot of the patients typically 10 years ago would start out in my office with very basic reflux and heartburn symptoms. And those have kind of unfortunately gone away for us. They were very easy patients to see and manage. A lot of patients now have access to a lot of different acid reflux therapies that they can buy from their local pharmacy. So now by the time we're seeing the patients as a specialist, they've kind of really gone through the gamut of treatments. And so we're seeing a lot more refractory patients being referred to us from either surgery, from ear, nose, and throat specialists, pulmonologists, or from primary care doctors, really just who are having a real hard time controlling their symptoms with medications is a very frequent referral now pattern we're seeing.
Yeah. Annie, tell us a little bit about what types of symptoms that you, how long were you suffering for GERD?
A good 4 years, and Dr. Conti put me on a PPI. And toward the last 2 years or the last 18 months before I had the TIF procedure, I was breaking through the PPI, and my symptoms were heartburn and acid reflux like round the clock. And I had pain, I had tightness in my chest. I had trouble going to the restaurants because I didn't know what I could really eat. And then I would get this choking sensation, and everybody thought, wow, what's going on with her? And it was just, it interfered with what I was doing activity-wise at the gym. And I do mosaic art, so I have to pick up a lot of tiles, and I have to sit down. And every time I was sitting down, I was getting this chest pain, and everything was just like bothering me. I got to the point I couldn't even take vitamins. I mean, like heartburn.
Wow, that sounds intense. So when did you decide that the TIF was the right move for you?
Well, I had been seeing Dr. Conti, and we were using the medicine, and then I ended up in an emergency room at Newport Beach one summer, and then when I came back from the summer, I saw Dr. Conti, and I said, well, what are we going to do about all this? And he said, you know what, I have TIF. So he explained to me what it was, and I decided to go through with it. I have to tell you, it's important when you're suffering from GERD and heartburn to find the right GI person, doctor for you, because you have to have a compassionate person, someone who really cares about your health and wants you to get better, instead of telling you to just go home and take something over the counter. So Dr. Conti was all of that. He just was really caring, compassionate. I mean, he's a brilliant clinician, and he's my rock star. So we decided to do it a year ago, and I went ahead with it.
Okay.
And it's really changed my life because I don't have any of that nonsense anymore in my chest.
Wow. Yeah. So I understand you even had your procedure, was it just before COVID hit? Is that right?
Yes.
Okay.
Yes.
Okay.
I had it
And
on the 25th of February, and then I probably saw Dr. Conti around the beginning of March, and then everything got closed down. So I was to him through my chart. So everything was good.
Okay. And the healing process and everything that you had to go through, I mean, it was probably an interesting time, with the shutdown and everything. How was that, the diet and everything that you endured?
It was fine. The first 4 to 6 days is rough because you really can't really swallow anything. And sometimes liquid is even hard, but you have to try to keep yourself hydrated. And by the 6th day, you really feel like you're ready to move on to the next amount of food, which might be oatmeal or yogurt and that kind of stuff. And it's a slow process, away from it. But you have to be very patient because now you've got a new lifestyle and a new way of eating, and you can only eat specific foods sometimes.
Right.
And your stomach is a little bit smaller, so you can't, fill it up like you might have beforehand.
Sure. So Dr. Conti, can you talk a little bit about, what are the available options to treat GERD at this time? I mean, obviously we're talking about the TIF and Annie had the TIF, but what do you offer to your patients? We know, obviously, not everybody's fit for a TIF procedure. There's other procedures out there. So maybe discuss that a little bit, if you don't mind.
Yeah, sure. So kind of as we're developing this newer technology and bringing it out to the Valley, we've been doing a lot of combination procedures with Dr. Choe. And we're very careful and kind of methodical about who've been picking to undergo this new procedure. We want to make sure everybody has a good response and it's 100% success if possible. And so there's a lot of preoperative testing the patients are going through. So it includes kind of analyzing their swallowing function, making sure they have the right type of reflux symptoms through pH monitoring, and seeing clinical responses to medications as well. There's a few different options that are out there for anti-reflux surgeries. I would say for the most minimally invasive versions, the one being TIF and the second one being LINX, we've found that through different avenues, that TIF procedure seems to be a little bit superior to the LINX procedure as far as patient satisfaction and how patients are doing post-operatively. And then the procedure we're doing a lot with Dr. Choe is really kind of an expansion of TIF, and we're trying to find a way to help patients with hiatal hernias that are a little larger. So the straight TIF procedure, which is by definition incisionless, is really designed for some of these smaller hernias. So some of the patients have kind of small hernias. We always used to think, the way we were trained is that, you have a small hernia, shouldn't be that big a problem. Take the medications, you should be fine. I would say as my career has kind of developed over the last 10 years through doing a lot of pH monitoring and really having an interest in GERD, I found that a lot of these really small hernias actually are quite active, have a lot of symptoms, and sometimes very, very ineffectively controlled with medications. And pH monitoring really has helped open our eyes to that. And so it was. I think TIF really hit a sweet spot because we had these very small hernias, and we felt it was difficult to send patients for a very large operation. The Dr. Choe was typically performing before something called Nissen fundoplication. And then what we're really trying to develop now is trying to find a happy medium for these larger hernias, because TIF is really only designed for a certain size hernia. But I would say a fair amount of the patients that we're evaluating are outside of the standard size that we typically would use for just a TIF procedure. We have a much older patient population. So typically we're seeing some of these hernias that have been there for a long time. So they're typically can be a lot wider in diameter and length, and would not be able to be fixed with TIF alone. So that's really where we're trying to collaborate and offering a new style of surgical repair, but keep it as minimally invasive as possible. And so the collaboration between me and Dr. Choe really has allowed us to kind of change the operation, so to speak, where Dr. Choe's surgical times and the amount of surgery that he has to do internally is reduced. And then by me doing the intraoperative fundoplication, we're seeing really good results with minimal recovery for the patients.
Fantastic. Thank you. And it's my understanding for Annie, you had a straight TIF, right? You did not have a hiatal hernia repair, correct?
Right, correct.
Okay. So her hernia was not that large. So can you explain, and then I want to kind of go to Dr. Choe and have him discuss, the hiatal hernia portion of it. But can you explain the TIF procedure and how it works, if you don't mind, Dr. Conti?
Okay. It's kind of hard. It's kind of hard to do without like having a nice
graph.
Yeah, the graph. I have to say, I will direct people to Endogastric Solutions, so I'm sure they're watching this Facebook live stream. But Endogastric Solutions has a wonderful kind of animatronic video that they really could do a much better and eloquent job of explaining what a TIF is through a cartoon. But essentially, in a nutshell, really what the TIF procedure entails, as far as the endoscopic fundoplication portion, is a device is inserted through the patient's mouth. Using that device, it has a kind of a retracting mechanism that we're able to kind of retract and pull down small hiatal hernias. When Dr. Choe is doing it, the hernia has already been reduced and it is in place. So all I'm doing is essentially creating the fundoplication. The retraction device kind of pulls into this clamping mechanism. Clamping mechanism is then firing plastic sutures across the esophageal and stomach intestinal mucosa, and basically creating a little bit of a shelf. This shelf is then fibrosed and scarred in place, and it's essentially working as a kind of a barrier to prevent food regurgitation, acid from entering into the patient's esophagus.
Perfect. Thank you. That was good, even without it.
I've done it a few times. I had to explain it many times on the fly. It never gets easier for some reason.
Should roll off your tongue, right?
It should.
I know Dr. Choe has some slides to explain the hiatal hernia portion of it. Do you want to pull those up and kind of explain how? There's a question here from a patient that's asking, how do you guys partner together, and how does it work? So this is good. This will hopefully build a picture of how you guys do that together.
So I hope the slides are up for everybody.
I can see them, yeah.
Perfect,
yep.
Perfect.
We're good.
So we have the normal configuration here where the esophagus penetrates through the diaphragm, which separates your thoracic cavity and abdominal cavity, and then the esophagus and the stomach join. A hiatal hernia is where anywhere from a proximal portion to a majority of the stomach can then escape up into the chest through a larger opening in the diaphragm. And so that's what a hiatal hernia is, the stomach moving up into the chest. And what this does anatomically then is create the situation where it promotes reflux disease. Oops. Okay.
There we go.
Let me get that back up here. So in a normal configuration, you have the apex of the fundus or the stomach close to the diaphragm. And as it herniates up, it creates this reverse funnel, whereas gastric contents are churned within the stomach, they get pressed up into the esophagus, promoting GERD. So that's how what Dr. Conti is seeing in all the testing is being proven in terms of physiology and why it's important to fix these hiatal hernias to allow patients to receive benefit.
Perfect. Thank you. Oh, yeah. Did you have more?
No, that's it. That's it.
Sorry, I didn't mean to interrupt you. Maybe you can explain kind of what would a patient expect if they were coming in to do, the combined surgery? Who would they see first, and how would that orchestrate in the surgery or operating room?
That's an excellent question, because really they can come from any avenue. They can come to me first for their hiatal hernia, being referred by a primary care or even other gastroenterologists. Sometimes they'll see Dr. Conti first. So it really goes back to this technique is available for anybody. It's just a matter of selecting the right patient for the right procedure. And that's where all the testing that we do beforehand really, really helps. Just like for Annie, she didn't have a hiatal hernia per se, but her testing showed that she had reflux disease and she was refractory to medication. And so this is where doctor's expertise and mine come into play, where we can fit techniques to our patient, not a patient into a technique, if you understand my saying.
Yeah.
There's variable treatments available, and it's just a matter of what's best for our particular patient. And then when we collaborate, Dr. Conti and myself, whoever sees the patient first, we both evaluate the patient, make sure the patient understands both aspects of the surgery, and are comfortable with us and have answered all their questions and concerns, have done all the testing appropriately to make sure that this is the right patient, right procedure for the right patient. They come into surgery, I'll do my portion first in terms of reducing that hiatal hernia, returning the gastric anatomy to as normal as possible, which then frees up Dr. Conti to really come in and do that stomach wrap or fundoplication and to provide that real treatment at that point.
Right. Yeah. Dr. Conti, anything else to add?
No, Dr. Choe did an excellent job of explaining, and really it is we have a really good collaboration, the two of us, and so we've been moving patients back and forth a lot, and like he was saying, we see referrals from all different angles now, and as the program's been expanding, even some of my colleagues are also getting involved, and as we're getting more comfortable with the procedure and the new technology, that's another avenue too. So other gastroenterologists in the community are starting to refer to us to have this new technology performed on their patients as well.
That's great. And I really like what you were saying, Dr. Choe, kind of that personalized approach to their treatment option. It's not just you're looking at someone personally and looking at what their disease state is. And so I really like that. Thank you. We have a couple of questions that have popped up on Facebook. So I'm just gonna, if you guys don't mind, we're gonna try to answer some of these questions. We've got Mitch asking, does the TIF damage the vagus nerve? Because the staples seem to go right over it.
Valid question. We don't think so. Especially when we're doing the combination procedures with Dr. Choe. One of the advantages of having that combination procedure done is Dr. Choe is actually able to identify the vagus nerve carefully, sometimes dissect or make sure it's not interfering with the surgery. And then when he's reducing the stomach, typically we're not involving the vagus nerve. But it's not, we can never say with 100% certainty there cannot be an injury to the vagus nerve during any one of these surgeries. So it's a valid question, but unfortunately the answer is no, no guarantees. But because of the minimally invasive nature of TIF and how it's done, we think that it's the best option for trying to avoid those complications.
Okay, thank you. We've got a comment from Corleen. She said she had her TIF 2 weeks ago. She's had no acid reflux since surgery. Fantastic. Her liquid diet ends today. Yippee, she said. Soft food diet starts tomorrow. Looking forward to it, she said. So congratulations,
Awesome.
Colleen. Yeah. Then we've got, let's see, Andrea, she's asking, since there are numerous fasteners placed around the LES, does this limit the LES muscle from contracting and closing?
Typically, if we're doing it correctly, actually the fasteners should be above the LES. And so when Dr. Choe is essentially reducing the stomach, or when we're doing this procedure, ideally what we're doing is the fundoplication wrap is kind of an involution, if you want to think of it that way. Essentially when we're bringing the stomach down, it's kind of involuting onto itself. And the fasteners are generally placed above where the LES is. So we're using the Z line as a target. The LES is kind of a long muscle, so some of the fasteners may go into part of the LES, but typically the LES function is preserved ideally. And then also the way the valve is created, it's supposed to give this kind of omega shape to it. So we're actually kind of reinforcing LES function with the valve. It is important that patients have a very well-functioning LES, and that's one of a very good point that they brought up inadvertently. And so that's part of the testing. Especially in our older patients that may have swallowing dysfunction, we always have to kind of figure out, make sure LES competency is working well before we move forward with any of these anti-reflux surgeries.
Perfect, thank you. Anything to add, Dr. Choe?
I agree. It's very, very important to do the proper testing so you're giving your patient the best treatment possible. And that's the key, really, is if they're not getting the testing beforehand, then it really is a crapshoot as to whether you're going to hit a vagus nerve or incorrectly augment the LES. You're just not doing it right. And so Dr. Conti and myself, we're very, very fastidious about getting all the testing completed before surgery.
Perfect. Thank you. This question is for Annie. What part of your life has been impacted the most since your TIF procedure?
I don't have heartburn or acid reflux. I can still have a cup of coffee in the morning.
Fantastic.
No wine, no red wine. I like vodka. I can just get on with my activities, and I don't have to be worrying about, am I going to have acid reflux in my throat?
That's awesome.
Yes.
Awesome. Any activities? Were there, I know you mentioned what you do as far as picking up the tiles and doing the mosaic work. Is there any other activities, physically that you weren't able to do previously that you're able to do now?
Right. I was having a problem lifting weights because, you're doing the whole upper body thing and you have this GERD there. Yeah.
Yeah.
So that's all much better.
One of the questions we get quite often, actually, doctors, is, how soon can I go back to exercising after my TIF procedure or, combined procedure? What do you guys normally prescribe for physical activity or working out? Or
you could go for that, Steve.
Yeah. For a hiatal hernia repair, it's a little more intricate because you are repairing a defect in the diaphragm, and that takes time to heal. And minimum 6 weeks. I recommend going to 8 because you really want to protect yourself and protect this investment you've just made for your future. So if you can give it 8 weeks of no heavy lifting, nothing too strenuous, it really allows the scar to form, which is going to maintain that repair for the length of your life. So I recommend minimum 6, ideally 8. Again, the larger the hernia, the more time I recommend.
Perfect. Thank you. So Mitch he's got a lot of questions, so I'll try to we'll get through this. Can you use skin as a patch over the hiatal hernia? This one for you, Dr. Choe.
No, you really don't want to use any patches or other type of artificial augmentation because through training, specialized training, you just realize they end up causing more problems than benefit. All the data and research has shown that and when you go in to try and fix something that wasn't done properly or failed for whatever reason, it just is a nightmare to get through that tissue again and increases risk for injury to the esophagus or stomach. So when I perform hiatal hernia repairs, and from my extensive training, it is done with no artificial augmentation, no mesh, and to just use proper technique in terms of no tension on the tissue or minimize as much as possible.
Perfect. He has another question. Do some people, let's see, I think he's saying dissection, not detection. Method for hiatal hernia seems unreliable. Some people retest and it says their hernia shrunk. What are the consequences of getting TIF if your hiatal hernia is actually quite large? So probably, I think what he's asking is, what if you get a TIF but not fix the hiatal hernia?
It doesn't work. That's it. And so that's why we're very careful in how we select the patients. The issue really is that the fundoplication is an internal wrap. And so in order for it to really ideally work to the 100% benefit, it needs to be in the right position, which is below the diaphragm. And so if we, by accident, or sometimes it's hard to judge some of the size of these hernias, and we don't have a measuring stick, so to speak, when I'm in there taking all our measurements. And so we're using a couple different modalities through imaging, manometry, endoscopy, to try to figure out the size of the hernias. But ideally, for the fundoplication to actually be successful, it needs to be below the diaphragm. And so that's why we're doing a lot of combination procedures, because most of the hernias we're evaluating really have they're either borderline or they're just a little too large. And we feel that really, ideally, just doing even sometimes a very small diaphragm repair will make the success of the TIF procedure by itself much more, robust and likely to last for a longer period of time.
Yeah, perfect.
And you're right. It's very easy to miss a hiatal hernia, unfortunately, for any number of reasons. It is a dynamic environment. The stomach is moving. It's a mobile structure. That's how it gets into the chest. A case we just had that we shared, Dr. Conti and myself, it wasn't necessarily so much all the stomach. There was actually a lipoma that was associated with the esophagus that was contributing to the dysfunction. So to get in there and really clear that out and make it a space that's available for Dr. Conti to do the TIF procedure was huge.
Yeah. And that's a one we certainly probably would have missed. I mean, honestly, when all our evaluations are done internally using different techniques. And so I can't really see things that are going on outside the stomach and in the abdominal cavity. And so it's a little bit of a guessing game, but we're trying to take as much of the guess out as possible. And so doing a lot of these surgeries together, it's really helping us kind of narrow in the focus and figure out who's best for what type of procedure.
Yeah, I like that. Thank you. Andrew, we've got actually a question from Andrew. He's 33. He's been on PPIs for 12 years. It is 70% managed. At what point would you consider TIF or something similar?
It's a very good question. I think that's another population of patients that's becoming a significant up-and-coming population. As acid reflux therapies in general, they start to get a bad rap as far as long-term use. Certainly every few years we see a publication released about the harmful effects of acid reflux medications. I can say with certainty there's good data out there to show that osteoporosis rates are definitely increased with acid reflux therapy just by the nature of the decrease in calcium absorption. As far as some of the other things that have been mentioned, like heart disease, dementia, kidney issues, patients ask me all the time, are these medications safe? I don't have a real answer for them because those medication side effects really have not been shown with statistical significance that they're an issue. But I would say that's a really growing population that's looking for alternatives to medications. And so the exciting thing about having minimally invasive surgery available to them, we can potentially offer a new treatment modality for them that does not involve medications. And when I talk to the patients about TIF procedures, I don't tell them 100% that they're going to be off medications. The studies basically show 6 to 8 out of 10 patients will be able to stop their medical therapy after they have this procedure done, but not a guarantee. There's a lot of wild cards in there, how their lifestyle is, stress factors, dietary habits. But certainly we can definitely make improvement in how much medications they do require once they have the procedure done.
Fantastic. Let's ask Annie. Annie, are you still taking your medications?
No, I'm not. No, I'm not. If I haven't eaten healthy, then I might have to take a Pepsid. But generally speaking, I haven't been on any medication and I don't want to be. So I'm doing fine.
Fantastic. Do you normally have, Dr. Conti and Dr. Choe, patients stay on and stay on PPIs right after the procedure, or you have them right off of PPIs?
I came right off. I hadn't been on it for about 2 weeks, so I didn't take any when I got off.
Okay.
Yeah, that was great.
I've been asking patients to potentially remain on it for just a few weeks, for about 30 days, just to kind of keep the acidity down as the sutures and everything's trying to heal. That's the only reason. I don't know, honestly, if that's the right thing to do. It's kind of more anecdotal, but we just figure let the environment in the stomach be as healthy and receptive as possible to the surgical technique. So typically I am recommending about a 30-day medication continuation. Generally their diet is so augmented because of the surgery itself, so they don't have a lot of reflux, so it's probably a little overkill. But after 30 days, we're allowing them to try to wean off and see how they do.
I think it's important to stay on medication while you're healing. GERD is very inflammatory. Anytime I'm taking down a hiatal hernia on a patient who's had GERD for a long time, the stomach or esophagus can be plastered to the thoracic wall. That doesn't happen in patients that don't have GERD. So we know that reflux disease is transmural, meaning full thickness of the wall, leading to scar tissue. And you don't want that intense inflammatory response. So anything you can do to mitigate that is good. So
yeah, great. Thank you. Another question from Andrea. What is the expected lifespan for a C-TIF? Is it as durable as a traditional fundoplication?
I'd say the jury's still out, but it's, obviously this procedure has not been around as long as standard Nissen fundoplication, but it is something that they're studying very closely. It does look comparable head-to-head, equal as far as the standard Nissen fundoplication is, as far as how long it's lasting for, because we are seeing patients that have had the first generation of TIF procedures now out 8 years or more, and some of them are still doing very well. But you're right, there is a failure rate for all anti-reflux surgeries. We're trying to do the best we can, and I think that's why the combination procedure is really going to, I think, rise to the top eventually. We're going to see that repairing the diaphragm in conjunction with the endoscopic fundoplication is really going to be, I think, the leading way to treat reflux going forward. But obviously, there's other options out there, and it's not designed for every hernia. So the standard Nissen fundoplication will still always be there and necessary many times.
Yeah, thank you. One last question before we kind of conclude. And Ryan's asking, he's been on PPIs for 24 years, Nexium and Nexium. What is the difference between TIF and the Nissen fundoplication? Dr. Choe, maybe you can, or you both could kind of explain the anatomy, how that's different.
I guess really. The Nissen is the gold standard for a reason. It's what's been proven to provide the most benefit for the longest period of time. That said, it really depends on the clinician that you have, the surgeon that you work with. If you have one that does it once a year, it's not going to be as reproducible, or the quality is not going to be there as someone who does it every 5 a week. So that's where I think TIF really comes into play, is that it takes some of the finesse, if you will. It's a very technically challenging procedure, and if you don't have the right surgeon doing it over and over again, your results will be variable, unfortunately. And I think with TIF, it takes some of that out of it. It's not complete, but at the same time, just from watching Dr. Conti progress through it, I'm going, wow, it takes the guesswork out of how much tension. Did I get the stomach too tight? Is it too loose? Is it exactly in the right place? He can see exactly what's happening from the inside. After a Nissen, I go in with the scope and check my work to make sure. So when it comes to it, I think in the long term, just like Dr. Conti's saying, the combination probably will win out just by virtue of reproducibility and results.
That's a good point.
Because what's really interesting about the combination procedure is Steve hit it right on the head. There's parts that the surgeon has to do from the outside that obviously I would have a hard time understanding when I'm internally inside the patient doing my procedure. And so it makes it ideal for Dr. Choe to be able to do the dissection, pull things down, get fat out of the way, really repair the diaphragm down to almost an ideal size. And then the fundoplication, where we're really trying to help with the reflux issues, he was guessing from the outside. And so now we've kind of brought a new piece of technology in that we can now do the actual fundo part, or the wrap, from internally, and really try to finesse it and make it exactly the size that we want, the length that we want, and in real time. And so, like he was saying, if you have a really skilled surgeon who's trained properly and who does a lot of Nissen fundoplications, they're probably going to hit it on the money every time. But when you have surgeons that are maybe dabbling in fundoplication and Nissen, certainly there can be not as good outcomes. And so it's kind of really combined the best of both worlds. And I think that's really going to show in the long run.
Fantastic. Perfect. Thank you. Well, we're coming down to the end, but before we conclude, Annie, I'm going to throw it over to you. Do you have any advice for patients that, have gone through the same thing that you have gone through? What do you say to them, or what do you advise them to do if they have GERD?
I really don't think there's no need to suffer with GERD. And if you can work well with the GI that you've chosen, and perhaps, the medication works for you and you don't have the kind of episodes that I had, then that's fine. My husband is managed on a medicine and he does really well. it was just interfering with my life too much. So it was better for me to go ahead and do the procedure.
Yeah, perfect. Thank you. Be your own advocate, right? I always say
Yes.
that. And then, next month is April, and it's actually Esophageal Cancer Awareness Month, which we're trying to obviously, and maybe you can talk, both of you guys can talk, doctors, about GERD and esophageal cancer, and is there a correlation, and what, maybe talk a little bit about that.
Sure. Not to bore our audience too much, but certainly there is a significant association with acid reflux disorders and the development of esophageal cancer. Statistically, we think about 5 to 10% of patients who suffer from reflux will have a precancerous condition known as Barrett's esophagus. And essentially what Barrett's esophagus is a change in the mucosal lining of the lower esophagus just from constant injury of acid splashing into that area. And we believe that Barrett's esophagus, although it sounds really bad, honestly, most of the patients who have Barrett's will not necessarily get esophageal cancer. So I don't want to scare everybody out there who's listening who knows they have a diagnosis of Barrett's. It's only a small section of the patients with Barrett's esophagus that will then go on to potentially develop esophageal cancer, somewhere in the order of 7 to 10%, we think. But it brings up a very good point that, understanding what GERD is and what your symptoms are, how long you've had symptoms, really just talk to your clinician about it. You should have some kind of endoscopy done to visualize the area and screen you, especially if you've had symptoms for more than 10 years, making sure you do not have the precancerous condition. And the patients who do have Barrett's esophagus typically are in some kind of surveillance program that we're watching them closely to hopefully help them prevent getting esophageal cancer. And then how that ties into TIF and hiatal hernia anti-reflux surgery. There are a lot of patients that I do treatment for Barrett's esophagus, trying to get rid of it. There's certain endoscopic therapies that patients can undergo to help reduce their risk of esophageal cancer. And anti-reflux surgery is part of that, because just treating the Barrett's, in a patient who has a hiatal hernia, likely they're going to get possibly injury again over time. And so some of them we really are looking at closely to see whether or not they would benefit also from anti-reflux surgery in addition to treatment of their Barrett's.
Perfect.
I agree. The medication hasn't been proven to prevent the progression to disease, to cancer. It's an ugly C word, and it's real. And unfortunately, you don't catch it until it's too late, because they do take these PPIs, or they live with their new normal. Annie was suffering, and she thought this was normal until even the medicines didn't work. So there's a lot of patients out there that think this is normal because everybody has heartburn, but it's not. And so you really have to rely on your clinicians and be your own advocate to a certain extent. Say, hey, I would really appreciate surveillance, meaning at least endoscopy, appropriate biopsy from your gastroenterologist, and then understanding what are the options here, because if you're on lifelong PPI, the cancer is not out of the picture here. Right. So you really have to look at family history, what are the other risk factors, and do the appropriate surveillance of catching Barrett's early, because it is a progression of disease from non-dysplasia to dysplasia and then to cancer. So to get it early is key, and unfortunately that gets missed.
Yeah, it's a good point. We here at Endogastric Solutions lost one of our own colleagues about 1.5 years ago from esophageal cancer. So it's close to heart for us, and that's why we're doing our best to raise awareness around it and GERD. So thank you for answering that and bringing those points up. We really appreciate it. So I can't thank you guys enough. Again, Annie, for being here and telling us your story, and Dr. Choe and Dr. Conti, thank you so much for taking time out of your day. I know you guys are really busy as well. So we appreciate your time. But before we go, remind everyone where they can, I think all your contact information is on the screen right now. So if you are in the Rancho Mirage area, or I should say the whole Palm Springs, Palm Desert area, right?
Southern California.
Even Southern California. There you go. You can drive in to the desert.
They do.
Dr. Choe and Dr. Conti. And then any should they just reach out to your office if they want to schedule an appointment with you? What's the best way to see you guys if they want to see you?
Yep, just give my office a call.
Yeah, you'll probably have better
bashful.
luck. No, and you'll probably have better luck getting into Steve's office because I have a real long wait list. So go see Steve, come see me. We'll take care of your reflux, but be patient and persistent. Things are taking off in a big way for us, and obviously with the pandemic, we had a significant backlog, and we're just really trying to catch up on things. But we're happy to be offering this service to all the people of the Coachella Valley, and so that's all I have to say.
Fantastic. Well, thank you guys very much. And if you're not in Southern California or don't want to fly out there, we do have GERDhelp.com. You can go visit that website, and on there, there is a physician finder. You can put in your zip code or your state, and you'll be able to find a TIF trained physician in your area. Again, I can't thank you, everybody that jumped on and asked questions. Annie, thank you. Dr. Choe, Dr. Conti, thank you both for being here tonight, and catch us next Tuesday for our next TIF Talk. Thank you very much. Have a good night.
Thank you.
All right, thank you. Thank you, everyone.